Welcome to this disease state presentation on left ventricular ejection fraction in heart failure. I am pleased to introduce our medical expert, Dr. Michael H. Picard, professor at Harvard Medical School and physician at Massachusetts General Hospital in Boston, Massachusetts. This presentation will not include discussion of specific treatments and is unbranded disease state education. This presentation is sponsored by Novartis Pharmaceuticals Corporation, and Dr. Picard was compensated for his time.
So as you heard, today I'd like to talk with you about our measurement of ventricular function, the left ventricular ejection fraction, and its integration in our care of patients with heart failure. My goals are to provide a brief historical perspective on the ejection fraction as a measure of heart failure, to describe some of the future potential approaches that we will use both with imaging and biomarkers in the management of heart failure, and then to look at the trajectory of care of patients across the spectrum of the left ventricular ejection fraction. So before I provide a historical perspective on the ejection fraction, I think it's important to note that the ejection fraction is synonymous with echocardiography, and echocardiography is synonymous with the ejection fraction. Certainly the echo is probably most commonly ordered to assess ventricular function. But I want to highlight that there's many more things that we do with the echocardiogram, particularly with the heart failure patient, so that when a patient presents with either confusing symptoms that may be related to heart failure, or maybe they have classic symptoms, we'll use that echocardiogram not just to measure the ejection fraction, but also to look at potential etiologies, whether it be valve disease or ischemic heart disease, congenital heart disease, maybe even obstruction from hypertrophic cardiomyopathy or infiltration from amyloidosis into the heart. Today, we will focus on the ejection fraction, but I think we should keep in mind the many other uses of echocardiography and other non-invasive cardiac imaging techniques. The ejection fraction is our most common approach to measuring systolic function. It's really a measure of the change in cavity size or left ventricular volume over the course of the cardiac cycle. And so we derive this by measuring the end diastolic volumes and the end systolic volumes, and then create that ratio of stroke volume over end diastolic volume, with the stroke volume being the difference between the end diastolic and end systolic volumes. It's important to remember that we're not looking at the intrinsic myocardial function with this measure. We're only looking at the change in the cavity, which is a response from that myocardial function. And so the ejection fraction can be dependent on loading conditions, both preload and afterload. But despite that potential limitation, it's really stood the test of time. It's really the currency that we as clinicians use when we're communicating about individual patients. It's, I think, a practical gold standard, or a practical reference standard. Now, the left ventricular ejection fraction has many roles in the management of our heart failure patients. We use it to diagnose, particularly in patients who maybe present with atypical or unusual symptoms. We use it as a marker of prognosis. As we move into an era of shared decision-making with our patients, it's important that we understand the potential prognosis of our patients so that we can discuss that with them. We use the ejection fraction to identify specific treatments that they may be eligible for, where there's a specific ejection fraction above which we wouldn't use and below which we would use. We monitor the response to therapies a bit with the ejection fraction. And over the last few decades, the ejection fraction has been an important gatekeeper in selecting patients for clinical trials. If we look at this slide, you can see that over the last few decades, there have been many trials related to heart failure, and most of the heart failure reduced ejection fraction trials have used ejection fractions of 40% or maybe 35% as that upper limit of normal to identify patients eligible. And interestingly, I think because of that use of the ejection fraction as a inclusion criteria, many clinicians will think of that certain treatment tested in that trial based on the ejection fraction. And I hope as we get through this talk, we'll see that we probably should move beyond that thinking and really look at treatments across the spectrum of ejection fractions. Professional cardiac societies have variable thresholds for their definitions of heart failure groups based on the ejection fraction. For example, the American College of Cardiology, American Heart Association, in their heart failure guidelines, use the cut point of 50% to separate the HFpEF from other heart failure patients, the 40% as their cutoff value to define the reduced ejection fraction. And so there's that mid group between 41 and 49% that they refer to as borderline, and in some situations even preserved ejection fraction. The European Society of Cardiology very similarly has the same differentiating points for HFpEF and HFrEF, and they use the terminology of mid-range ejection fraction for that 40 to 49% group. Most recently, the Heart Failure Society of America, in collaboration with the Heart Failure Association of the European Society of Cardiology and the Japanese Heart Failure Society, have developed new standards, new definitions and terminology. And again, the 50% and 40% cutoff points are used for HFpEF and HFrEF, but they now call the group with the EF between 41 and 49% heart failure with mildly reduced ejection fraction. And they've added another classification, and that is the heart failure with improved ejection fraction. This is a group of patients who start on their baseline ejection fraction assessment to have an EF below 40%, but they improve at least 10 percentage points over time, such that on follow-up, their ejection fraction is greater than 40%. Now, in addition to the guidelines, there are also normal value determinations from the various imaging societies. For example, the American Society of Echocardiography, in collaboration with the European Association of Cardiac Imaging, in large population studies, have found that males have different normal values for ejection fraction than females. Based on that, they define their mildly abnormal, moderately abnormal, and severely abnormal ranges of ejection fraction. In contrast, the British Society of Echocardiography has found that the normal value, lower limit of normal, is actually 55% in their population studies. Just in the last few months, the Heart Failure Society of America, in collaboration with the Heart Failure Association of the European Society of Cardiology and the Japanese Heart Failure Society, have developed and published a universal definition for heart failure. Now, in this document, most importantly, the terminology has changed for that mid-zone 41 to 49%. It's called heart failure with mildly reduced ejection fraction. And also in this document, a new class is identified, the heart failure with improved ejection fraction. By using these definitions, these cut points for ejection fraction, again, if we look at the clinical trials that have been performed both for HFpEF and HFrEF, there still is some differences in terms of how the trials define or use ejection fraction as a cut point, and how these societies are using ejection fraction to define their syndromes. The nice thing about this universal definition for heart failure is that we have this improved ejection fraction class, which is a very important class as we care for patients. And also, I think we now have a consistent terminology for that mid-range, that mildly reduced ejection fraction group. The challenges, of course, are that mildly reduced ejection fraction group is a very heterogeneous group. It may be some of the patients who are actually moving from HFrEF up and out of HFrEF. It may be patients who are deteriorating from a HFpEF class, and there may be patients who are just constantly in that mid-range ejection fraction. And unfortunately, with that one snapshot, we don't really know who those patients are and where they will end up. So again, despite our attempts at really clear definitions, there's still heterogeneity in our groups of heart failure patients. The ejection fraction is just one approach or one of the many characteristics that we use when we identify our heart failure patients and think about the mechanisms of their disease. I think it's important that we think about the comorbidities that these patients have, their state of inflammation that they may be under that's causing some of their symptoms and cardiac dysfunction, and importantly, cardiac remodeling. We'll have patients who have extensive hypertrophy, resulting in stiff hearts and impaired filling of their hearts. We'll have patients on the other end of the spectrum who have a lot of cell dropout from cell death, apoptosis, and fibrosis replacement. And they typically will be the group that has a reduced ejection fraction. And so in addition to thinking about ejection fraction, we should be thinking for each of our patients about what other characteristics help define them, because those are the things that will help us understand the pathophysiologic mechanisms of their disease. Now, another aspect of integrating ejection fraction and our thinking about cardiac function is the fact that we have our HEF patients, those with preserved or normal ejection fractions, typically manifesting diastolic dysfunction. And on the other hand, at the other end of the spectrum, our patients with a very low ejection fractions typically are manifesting solely systolic dysfunction. So we have the high EF with the small hypertrophied heart. We have the very low EF with a dilated, thinned-walled heart. But there's a wide range in between across a wide spectrum of ejection fractions where we may see that patients have a combination of both systolic and diastolic dysfunction. And unfortunately, we can't really rely on a specific EF to tell us what proportion of dysfunction is systolic and what proportion is diastolic. And so although our EF helps us at either end of the ranges of that measurement, in between we really have a combination of systolic and diastolic dysfunction, almost independent of the ejection fraction. Another pitfall of the ejection fraction is the variability that occurs. I've already mentioned that, that epidemiologic studies have shown us that males and females have different cutoff values for normal. But also as we look around the globe, different ethnic and racial groups will also have different normal values. And the ECHO normal study has shown that East Asians typically have higher values of their ejection fraction for their normal range than Europeans. The World Association of Societies of Echocardiography has recently published their data showing, again, East Asians, particularly Koreans, have higher EFs for their normal values compared to those from Europe and United States. And lastly, ejection fraction can change over time in an individual. And as the patients age, there is some fibrosis replacement that occurs, and it's always hard to decide, is this a normal aging process or is this the development of diastolic heart failure? But again, we may see some changes in the ejection fraction in individuals as they age. Any measurement that we make is subject to variability, and the ejection fraction is one of those. As we make our measurements of volume, whether it's on CT or MRI or echocardiography, there's going to be some variability. And that variability from observer to observer is a function of where one makes the measurement, where one identifies the endocardial borders. But if we focus on echocardiography, the standard approach to measuring ejection fraction is by measuring volumes with the biplane method of discs. And I think if we look at with modern echocardiographic imaging equipment with the current state of image quality, typically we're now seeing intra-observer or inter-observer variability roughly in the 5 to 8% range. And so I think that in general, one must consider that when you're thinking about your patient with a specific ejection fraction. Obviously, if the EF is 65%, then even if we include that variability, we're going to have a normal ejection fraction. It might be somewhere between 60 and 68%. The problem is when we've got that patient who's got a 39% ejection fraction. It could be anywhere from lower 30s to maybe into the lower 40s. And that may be important as we're considering certain treatments for patients where the treatments are based on that ejection fraction measurement. So it's important to keep that in mind. And it's also important in your practice groups to think about ways to reduce that measurement variability. And that can be performed with QA conferences where groups get together, the sonographers and the physician readers get together and really look at the images that they're measuring. And as a group decide and develop conventions on what are the targets that are going to be measured or how the endocardial border is defined. I would encourage you to take on those types of exercises. So we do have, I think based on what I've just mentioned, we do have opportunities to improve some of the imprecision that occurs in the ejection fraction, particularly as measured by echocardiography. We should use the biplane method of discs whenever possible. One can consider using contrast agent to improve the border delineation when the image quality is not ideal. Also, I mentioned earlier that the ejection fraction is load dependent. And so the blood pressure, a marker of afterload, is very important to consider when we look at ejection fractions. And I think that anytime you report an ejection fraction, you should know what the blood pressure was when that measurement was performed. We've also talked about some of the other factors that contribute to variability, such as ethnic and racial differences, sex differences, and all of those one should keep in mind when one looks at that ejection fraction measurement. And then lastly, as we look to the future, we now have the capability of measuring the ventricular volumes from three-dimensional techniques, whether it be in echocardiography or some of the other non-invasive techniques. And I think that as we move to three-dimensional measurements rather than two-dimensional measurements, we will have reduced variability. I'm going to switch gears for a few minutes and go back and talk about that universal definition of heart failure that was developed by the 3 professional societies on heart failure. Now, let's take a look at the proposed universal definition for chronic heart failure. As I mentioned, it comes from that writing group from the 3 professional heart failure societies across the globe. They define chronic heart failure as a clinical syndrome that has signs or symptoms caused by structural or functional cardiac abnormalities. And these signs and symptoms need to be corroborated by either elevated natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. And that can be confirmed by a variety of diagnostic modalities or hemodynamic measurements. Now, you notice that in this definition, we haven't mentioned ejection fraction. We have, though, very clear terminology, both based on clinical exam and objective evidence. And so I think this is will help us in communicating about our patients who have been diagnosed and are about to be treated with heart failure. As we look to the future and assessing cardiac function, there are a variety of new approaches that I want to call your attention to. The first is with echocardiography. We now have the capability with echocardiography of measuring the velocities of the myocardial wall, displacements and deformations of the ventricular myocardium. And these can be measured by a variety of different measures. We can look at the excursion of the base to the apex of the left ventricle by looking at the excursion of the mitral annular plane for the left ventricle or the tricuspid annular plane for the right ventricle. We can put Doppler assessments onto the myocardium and measure the speed or the velocity of that wall as it moves from base to apex. And we can track the specular reflections in the myocardium and look at different reflectors and how they change in length between the two of them over time to actually measure how the myocardium compresses and expands, and that's called strain. And so this strain assesses the relative length change that occurs during the cardiac cycle. And it occurs in the longitudinal direction in the circumferential direction and also in the radial direction. That radial direction is thickening, that circumferential direction is a myocardial twisting, and the longitudinal is that base to apex direction change. And importantly, we are now learning that these parameters that assess the myocardium specifically relate to the degree and presence of myocardial fibrosis. So although magnetic resonance imaging is still our gold standard for fibrosis imaging, we can use echocardiography now as a screen to identify those who have risk for fibrosis. And as you'll see, as I continue my discussion on global longitudinal strain, the strain parameters change before the ejection fraction. So it allows us a marker of subclinical left ventricular dysfunction. So let me get to that for a second. The global longitudinal strain is a marker of that longitudinal excursion during systole. Now, the left ventricle myocyte or myofibers really are oriented in a helical fashion. And the fibers that are in the subendocardium are longitudinally directed, whereas the fibers in the subepicardium are typically more circumferentially directed. Many of the processes that cause the ventricle to fail first occur in the subendocardium, particularly ischemia, but many of the other processes. And so it's those subendocardial myofibers that are impacted first as heart failure develops. And so that's why the global longitudinal strain will be first impacted as some of these heart failure processes begin. And interestingly, as that longitudinal strain deteriorates, the circumferential strain overcompensates. So the epicardial fibers will tend to work a little bit harder. And that's why the ejection fraction is preserved in this state, and yet the longitudinal strain will show us that early identification of subclinical dysfunction. Now, GLS has also been shown to be associated with the severity of heart failure based on natriuretic peptides. Many multivariate analyses have shown it an independent marker of outcome, whether it's cardiac mortality or many of the other markers that we look for in outcomes of heart failure patients, independent of all the typical measures that we use in our clinical assessment of these patients. So again, I think GLS is really up and coming and as an important marker in our heart failure assessment. In addition, it's interesting to look even maybe a little bit farther into the future and think about artificial intelligence, machine learning, and convolutional neural networks. These are computer algorithms that can identify the cardiac structures on our MRIs and CTs and echoes and make the measurements for us. And although humans will always have some variability in their measurement, computers are measuring exactly the same thing each time. So there should be a lot less or even no variability from measurement to measurement in these artificial intelligence approaches. And so I think we'll be seeing more and more of these automated measurement approaches in our care of the patients. And then secondly, proteomics and metabolomics and other metabolic markers are now being broadly measured and allow us to really understand some of the unique pathophysiologic mechanisms that occur in the range of patients with heart failure, whether it be HFrEF or HFpEF or ischemic or non-ischemic cardiomyopathy. Each of our patients have unique protein profiles, and these signatures really are going to allow us to more personalize the assessment and treatment of those patients, really get at the pathophysiologic mechanism. And again, independent of what the ejection fraction is. Let's just look at one other issue. You'll, I'm sure, be familiar with the A through D staging categories. We have stage A, which is the group that's at risk for heart failure. This is a group of patients who have no heart failure, no signs and symptoms, no objective evidence, but they have some risk factors. Maybe it's their hypertension or obesity or diabetes. Most of these patients will not go on to heart failure, but there is a group that is a future target to prevent heart failure. Stage B is what we call the pre-heart failure stage, and this is a group, again, that doesn't have signs or symptoms of heart failure, but they do have some marker, whether it's some structural heart disease or maybe abnormal cardiac function or maybe an elevated natriuretic peptide. And again, this is a group that we are starting to focus on to prevent the development of heart failure. And then stage 3 is our more classic patients who have signs and symptoms and have objective evidence, and the group that will be initiated if they're not already on guideline-directed medical therapy. Some, unfortunately, will become refractory to their treatments and require hospitalizations and maybe consideration of more advanced therapies, and that's our stage D, the advanced heart failure patients who have really severe signs and symptoms of heart failure and require consideration of advanced therapies. Although, again, ejection fraction may be one of the items that we'll use to identify structural cardiac changes and abnormal cardiac function, we can really move across these risks without changing the ejection fraction, or in some cases, in a stage, they'll have a high EF or a low EF. It's really independent of the ejection fraction. Now, lastly, let's take a look at the trajectories of care that we focus on across the spectrum of ejection fraction in our heart failure patients. First, let's think again about the EF and the complementary role that it plays in managing these patients. We use the ejection fraction to diagnose heart failure, to assess the prognosis, and also assess the response or lack of response to certain therapies. But it's important to keep in mind that that ejection fraction may not necessarily change in all patients who show a clinical or functional change in their status. So we may have patients who actually show improvements, and yet their ejection fraction stays flat or maybe even goes down. We have patients who show a deterioration in their clinical status, and yet that EF is not changing in the same direction. And lastly, as we'll see in the coming slides, our goals of management really are similar across the continuum of the heart failure classes, regardless of the ejection fraction. So let's think about our heart failure patients who maybe present to us in a decompensated state and require hospitalization, institution of aggressive intravenous medications to really get them back on track. And hopefully with the institution of intravenous therapies, we will start to see an improvement in these patients such that we can then, during that hospital stay, initiate oral therapies that will be the mainstay of their outpatient therapy. Some obviously may not respond as well and require other therapies. Some may stall at a certain point. But again, we'll initiate these guideline-directed medical therapies, start to optimize the dosing, discharge them obviously at home on a different diet and different exposures. They may require some tinkering with the doses of their guideline-directed medical therapy, but we really are then initiating the chronic phase of treatment of these patients. And again, as I think through that whole process, I am never mentioning the word ejection fraction, because the approach is really going to be based not only on ejection fraction, but particularly symptomatic response and how we do at reducing the systemic and pulmonary congestion in these patients. More specifically, let's look at 4 patients. Let's think about the HFrEF patient, the HFpEF patient, that mildly reduced ejection fraction patient, and that improved ejection fraction patient. And as we think through this, I want you to keep in mind the outcomes of these patients and the therapies of these patients. And I think you'll see that despite our classifying each based on their ejection fraction, many of the outcomes are very similar regardless of ejection fraction. And in fact, our treatments and treatment goals are the same. So we'll take our HFrEF patient and think about that patient. We are all familiar with the classic signs and symptoms that they'll present with. This is an illness that's going to affect both males and females. They probably have less of the comorbidities that we tend to think of in HFpEF, but they certainly have coronary disease and other factors. We typically, in terms of cardiac structure, will see a dilated heart, and so they have eccentric left ventricular remodeling. The mass may be up, but it's really a very large heart. And their systolic dysfunction we've defined by the ejection fraction of less than 40%. But their outcomes really are the typical ones that we think about in terms of rehospitalizations, ventricular arrhythmias, mortality, obviously, and worsening of their symptoms, worsening of quality of life. Now, let's consider that newly defined group, heart failure with improved ejection fraction. And this is that patient who's going to have an EF in that 40 to 50% range. Their signs and symptoms are going to be exactly the same as the HFrEF patients, maybe not as severe. This is a group of patients that maybe has a little bit of a different clinical profile. They tend to be younger patients, often female, typically with a relatively newer onset of their heart failure symptoms, a shorter duration of their heart failure. Hopefully that's one of the reasons that we've been able to get them to improve out of that low EF range. We may not see as much structural abnormalities on that initial evaluation. We've defined their systolic function in that 40 to 50% range, but their clinical outcomes are very similar to the ones that we discussed in the HFrEF patients. We hope that they'll have a better prognosis and reduced risk of mortality, but the issue highly depends on their compliance with medical therapy. This is a group, as they start to feel better, it's really critical that we don't remove the guideline-directed medical therapy. It's important that we continue that, otherwise they may relapse and move back into the HFrEF group. Now, our mild reduced ejection fraction patients, again, same signs and symptoms. Their demographics can be similar to the HFpEF patients or to the HFrEF patients. Their remodeling, again, is typically more like the HFrEF patients than the HFpEF patients. We, again, have defined their ejection fraction based on that 40 to 50% range. But again, when we look at outcomes, very similar to all the others, whether it be in HFrEF or HFpEF. And in fact, since this is a relatively newly defined group, we probably need to look at more investigations before we have a really good sense of the specific clinical outcomes that will occur. And lastly, let's think about the HFpEF patient. Again, we're familiar with their signs and symptoms, particularly of pulmonary congestion in these patients with stiff hearts. We see these occurring more often in women, particularly older women, particularly those who have obesity, metabolic syndrome, hypertension, renal dysfunction, and we tend to see a small hypertrophied heart. So this is LV concentric remodeling. Again, their ejection fraction has been defined, or the systolic function is normal and defined as an EF greater than 50%. And again, as sort of a broken record, when we think about the clinical outcomes, they really are the same across the spectrum of ejection fraction. As we looked at these vignettes, I hope you've seen the point that I was making before, that although it's important to classify our patients based on ejection fraction so that we can communicate and understand amongst ourselves, treatments may not change that dramatically across the ejection fraction range. And in fact, their outcomes may not be that different across the ejection fraction range. In this short period of time, I hope I've been able to stimulate your thinking about the management of heart failure patients and maybe where the ejection fraction fits in. Heart failure obviously is a continuum. It's based on signs and symptoms confirmed by structural and functional cardiac abnormalities. And the ejection fraction is an important metric, but it's only one that we use to describe these abnormalities. The universal definition doesn't necessarily include the ejection fraction, but as we classify heart failure subtypes, that's where we use the ejection fraction. And in addition, the EF has value in the diagnosis, particularly in identifying specific etiologies in those that maybe have nonspecific symptoms. We use it to identify response to treatments and also eligibility for certain advanced treatments, and also in assessing prognosis. Its role, I think, is evolving. We are moving to some newer measures of systolic function, as I mentioned, such as strain by echocardiography and with MRI. And I think we'll see many other new approaches in that realm. And lastly, as we think about the treatment of our patients with heart failure and their course, as I mentioned, their trajectory through hospitalizations and chronic outpatient care, this opportunity to optimize guideline-directed medical therapy really is independent of the ejection fraction, and it's something that we want to use regardless of what we're thinking in terms of that patient's systolic function.